Hi, everyone, and welcome to this brief podcast on medication treatment intensification for patients with hypertension. My name is Neha Sachdev, and I work at the American Medical Association as the Director of Health Systems Relationships. Joining me is my colleague, Dr. Michael Reikotz, who is the Vice President of Health Outcomes at the AMA. Mike and I are both trained family physicians, and we work with healthcare organizations, physicians and other providers, and care teams to implement evidence based strategies and action steps to improve blood pressure control. Over the next few minutes, we'll discuss using combination therapy or multiple medication classes to initiate and intensify treatment for patients who have hypertension and uncontrolled high blood pressure, or BP. I do want to take a quick moment to acknowledge the importance of non pharmacological interventions. Lifestyle changes that have been proven to lower blood pressure should be included in the treatment plan for all patients with elevated BP or hypertension. It's important to counsel and support patients to make sustainable lifestyle changes that can help improve their BP. So, getting back to antihypertensive medications, I've got two words to start with: therapeutic inertia.
Therapeutic inertia. Two words that keep me up at night. Let's talk about why therapeutic inertia is so important. Therapeutic inertia, which is a lack of treatment intensification when indicated, is one of the leading barriers to controlling blood pressure. There are a lot of contributing factors that can lead to therapeutic inertia, including health system, patient, and physician factors. One that I'd like to highlight is something we've all experienced: the use of soft reasons to delay treatment intensification. Some examples of soft reasons include not intensifying treatment for uncontrolled hypertension because a patient or provider believes that the blood pressure is high due to something other than hypertension, such as having a hard day at work, or just finishing a coffee drink before coming in, or having recently smoked a cigarette, or being off their medication at the time of the appointment, rather than due to hypertension. These are just a few of the reasons that can contribute to hesitation or inertia in intensifying treatment. If we can reduce therapeutic inertia, it would make a big difference in achieving blood pressure control for patients, possibly the biggest difference. Let me explain what I mean by that. A study published by Bellows and colleagues in 2019 looked at three key processes in the management of hypertension: adherence to treatment, intensifying treatment when blood pressure is uncontrolled, and frequency of follow-up visits when blood pressure is uncontrolled. The study estimated where we are currently in the United States with each of these three processes and what would happen to blood pressure control if we optimized each process independently of the others. Here's what they found. If adherence to antihypertensive medication at 1 year, which is currently 57%, was improved to 100%, blood pressure control would improve from 46 to 57%, an 11 percentage point improvement in blood pressure control rates. If visit frequency was increased from every 14 weeks to every 1 week, blood pressure control would improve from 46% to 68%. That's an improvement of 22 percentage points. Much better, but it's probably very unrealistic to think that patients could be seen every 7 days. And finally, let's talk about the probability of intensifying treatment during a visit when blood pressure is uncontrolled. If we increase the probability of intensifying treatment from 1 in 7 visits to 2 out of every 3 visits, blood pressure control would improve from 46% to more than 80%, by far the most impactful, and by itself would move the population to meeting the Million Hearts target of 80% blood pressure control. The main point I want to make is that focusing on all three of these processes will improve blood pressure control, but focusing on treatment intensification will have a much greater impact on improving blood pressure control than the others.
That Bellows article really demonstrates how much of an impact treatment intensification can have on BP control. So, how can providers and care teams improve treatment intensification? Well, one key change would be if more physicians and providers use multiple medication classes at lower doses to treat patients who have uncontrolled high blood pressure. What I mean by that is right now, a treatment approach that we commonly see is to start one antihypertensive medication class and then titrate it up to the maximal dose over several visits before starting an additional medication class. The alternative that I just mentioned is to initiate multiple medication classes or combination therapy at lower doses. Combination therapy leverages the therapeutic effect of each medication class because a medication initiated at half standard dose will have 80% of the BP lowering effect of that same medication class at a standard dose. Another way to think of this point is that initiating a medication class has about 3 times the BP lowering effect as titrating the dose of an existing medication.
That's a really great way to describe the impact of adding a medication class. In addition to lowering blood pressure more, using combination therapy can also help patients reach their blood pressure goal faster. US and international hypertension guidelines have recommended the use of combination therapy for years. The evidence for these recommendations is rooted in the fact that most patients will need 2 or more medication classes to achieve blood pressure control and will not be controlled with just a single medication. Probably the most important point about combination therapy that we haven't discussed yet is that initiating treatment for hypertension using 2 drug classes improves outcomes compared to using 1 drug. Rhea and colleagues published a study in 2018 that compared the risk of cardiovascular outcomes and death between patients who were prescribed initial antihypertensive treatment with 1 drug versus 2 drug combinations. These patients were then followed for the next 3 years. For those initiated on 2 drug combinations compared to monotherapy, the risk was 16% lower for having any cardiovascular event, 35% lower for heart failure, and 20% lower for ischemic heart disease. There was also a 20% lower risk for all-cause mortality. Those are all very compelling reasons to initiate treatment with 2 medication classes compared to monotherapy whenever possible. The same study looked at the percentage of patients started on monotherapy versus combination therapy who remained on treatment 3 years later. Of the patients started on monotherapy, nearly 2/3 remained on monotherapy at the end of the 3 years. For those started on combination therapy, nearly 80% remained on 2 or more medications at the end of the 3 years. This is important because, as I said earlier, most patients with hypertension will need 2 or more medications to get to goal. And if they're started on 1 medication, they're much more likely to remain on 1 medication over time, increasing the risk of a bad outcome.
So, I think we've covered why combination therapy is an effective approach to treatment intensification. Now, let's address some of the common concerns and barriers about using this approach in practice. The first question I'll raise is about adverse events or side effects. If 2 medication classes are initiated at the same time, does the risk of adverse events or side effects increase?
That's a very valid concern and one that we hear raised by prescribers frequently. Obviously, each situation is unique, and you have to use your best clinical judgment when prescribing medications for patients. What I can say is that when the data from studies comparing standard dose monotherapy and 2 drug combination therapy using low to standard dosing were compared in a systematic review and meta-analysis, using a combination therapy approach was better at lowering blood pressure, which you would expect, but without increasing the rate of medication withdrawals due to adverse events, which I think is surprising, but very important. Again, going back to the point earlier about the therapeutic effect, there is a greater impact on lowering blood pressure adding a new class of medications, even at low dose, compared to increasing the dose of an existing medication. So rather than spending months or years increasing the dose of a single medication, which may increase adverse effects from the medication, it makes sense to use lower dose of a combination of medications and potentially reduce the risk of patients discontinuing their medication.
That makes a lot of sense. It also strikes me that avoiding side effects may help with adherence to medications. Thinking about the patient perspective, less side effects is great, but taking 2 medications instead of 1 might be concerning to some patients. As you mentioned already, using clinical judgment is essential, and so is engaging in collaborative communication with patients about their blood pressure, their treatment goals, and their treatment plan.
Now might be a great time to introduce single pill combination medication.
I was thinking the exact same thing. Single pill combinations can be a great way to prescribe combination therapy since the number of pills a patient has to take remains the same, while the number of medication classes may be two or three. And they are usually dosed once a day, which makes them convenient for patients. When we've looked at prescribing data, the numbers of single pill combinations used tend to be very low. Compared to individual medication prescriptions for classes like ACE inhibitors or diuretics, single pill combination medications are just not prescribed as often. One concern that might contribute and that comes up often is the cost and availability of single pill combinations. There are combinations available as generic medications, and many insurance formularies, including Medicaid and 340B, have options for single pill combinations as preferred medications that do not need prior authorization. Discount pharmacy programs may also have single pill combinations available.
Single pill combinations are usually available, and in my experience, I found that many prescribers are unfamiliar with their availability as first tiered medications on formularies. I also want to mention that using single pill combinations as first line treatment for patients with uncontrolled high blood pressure has been shown to be feasible and effective in real world primary care settings. Many organizations and practices have been able to implement treatment protocols that use single pill combinations as first line medications, which have contributed to attaining very high blood pressure control rates in their patients.
You just mentioned treatment protocols, so I do want to elaborate a bit more on that point. An evidence based hypertension medication treatment protocol can serve as a great resource and guide prescribers and care teams at the point of care. A protocol does not replace clinical judgment or individual decisions. What it can do is help teams determine which patients need treatment intensification and what the treatment should be, including options for specific antihypertensive medications. We've seen protocols developed by organizations in house or adaptations or adoptions of existing sample treatment protocols. We've also seen protocols be embedded in the electronic health record, incorporated into clinical decision support tools like order sets or best practice alerts, or be printed and posted in clinical environments.
I truly believe that one of the best ways to integrate and increase the use of combination therapy and single pill combinations is to develop and implement a treatment protocol that lists specific examples of combinations that are low cost and dosed once daily in conjunction with frequent follow up intervals for patients who have uncontrolled hypertension. Protocols like this can serve as an important component of a systematic, team based approach to addressing therapeutic inertia, effectively treating hypertension, and improving blood pressure control.
I completely agree with you. And I know we could keep talking, but we've covered a lot of information already. So, to wrap up, we'd like to ask everyone listening to reflect on how you can improve treatment intensification in your practice or organization. Do you currently use combination therapy? And if not, why not? What can you do to improve treatment for your patients with hypertension and help everyone achieve their blood pressure goal? Thanks so much for listening. Bye now.
Thanks, everyone.